Hey, this is the Proactive Podcast. We're here in downtown Calgary, and we tackle everything health, fitness, and sports. My name is Dr. Matthew Jurgis. I'm with
Dr. Alex Fitzowich. I'm a chiropractic.
And today we got a special guest, Alex Paquin. He is a podorthist. Alex, tell me about yourself and what is a podorthist?
All right. Well, thanks for having me, guys. My name is Alex Paquin, based in Cork, BC. I'm the owner of Peak Orthotics. So we manufacture orthotics for health clinics and affiliate practitioners throughout British Columbia, Alberta. Podorthist. Well, I'm a biomechanical specialist of the lower limb. I focus on gait alignment and accommodating for various pathologies that can arise in the lower limb.
Gotcha. Yeah, so I've been super excited for this podcast, especially being in our field as kind of athlete-centered chiropractors. The foot and the kind of lower limbs are definitely, I would say, the most complex, like, biomechanical system in the body, and it really takes a specialist to break this down to a science. So I'm super excited. I know you got a lot. We got a lot of interesting kind of topics to tackle here. So can you? So there's a lot of kind of terms around podorthist, podiatrist, and what specifically, I guess, separates you as a specialist besides the other specialists there?
Sure. Well, the podorthist, from the base, we're kicking from the specialty of shoes and the act of walking. So we are specialists in how the gait functions, and how to align it better and how to accommodate for different, the bone deformities that can arise and slowing down pronation through phase of gait, that kind of thing. Podiatrist is more along the lines of, their specialty can also be in they do some gait and biomechanical alignment, but also, more in skin disorders, nerve, blood flow, more into internal soft tissues, where muscle and bones sort of thing.
Gotcha.
Yeah.
Cool.
But yeah, it's all a specialty of the lower limb nonetheless.
Right on. Mm-hmm. Okay, so getting right into it. So you've been the founder of Peak Orthotics for a while now, and so orthotics. When does someone need an orthotic, and how do people kind of? When is this a beneficial, support for people?
Okay. Well, I'm going to take your question and separate it into a couple of different things, if that's okay.
Mm-hmm.
The orthotics, we have to understand that a general term for foot orthotics, that there's a bunch of different functions within that, right? So we have typically what's called a functional foot orthotic, which is a device that corrects gait and angles. And then there's the accommodative foot orthotic, which its function is to not correct gait, but to accommodate for different pressure points and bring more comfort to the patient. This is two very different patients and different uses. We looked at this and through countless years of trial and error and building upon what we learned, we created a device that's more rehab specific. So we call it the Peak Rehab Dynamic Foot Orthotic. So you end up having elements, some accommodative elements and some functional elements, because we do correct gait with it, and some new elements that are been brought to the table by in a certain way, which I can demonstrate later, that, encourage extrinsic flexors to be activated through Gait. So we've got 3 different types of devices for 3 different types of patients. So to go back to your questions, when does a person need an orthotic? Well, it could be a lot of different factors that come in.
Mm-hmm.
You would have, your one example would be your elderly patient that would come in with, rheumatoid arthritis or osteoarthritis into the lower limb. And, for that patient, our goal would be to get that patient walking more comfortably so they can enjoy a better quality of life, walking more often and stimulating more blood flow and staying healthier longer, hopefully. So that would be the one accommodative kind of example. Then for a rehab type patient, then you would have, it doesn't even need to come from the knee, it could come from the foot, it could be coming from the knee or from the hip, and they come to a practitioner and say they have a knee issue and perhaps some patellar tracking issues, some pain underneath the kneecap, and you're looking at the whole alignment, and your first visual clue would be, this person's standing pretty aggressively on a genivalgum sort of knock knee angle, and so then you have a look deeper into the foot, you realize that patient's pronating quite heavily, which is the flattening of the arch more or less, and this person's compensating by externally rotating their legs and standing a bit on a duck stance. So you look at that patient and then realize that the strength of the glutes are a little bit weaker, vastus medialis a little bit weaker. Looking a bit deeper into it, you're realizing that there's not much strength into the big toe flexor. It's hard for that person to balance on the toes, that kind of thing. So we decided to go for a rehab treatment plan, and that would involve some exercises, some stretches, and some rehab foot orthotic to help stimulate those muscles when they're wearing shoes. So you see what I'm saying? That it could be like 2 very different patients, and so when does that need come in for an orthotic? It's most people treat it like there's a problem that comes up, then let's fix it, rather than being proactive about it. I'd rather see people be proactive about it, and we look into these things before the real problems come in. But often it comes from, there's a problem, so let's fix it.
Right. And I think that's one of the things that kind of separates your product from the pack, or kind of surprised me when I learned about Peak Orthotics, and obviously we fit people for those orthotics, is the idea of this is an instrument you can use to rehabilitate gait. And obviously that might not be the answer for everyone. Some people have, congenital malformations or whatever it may be, but for a lot of people, this can be a tool to as a fix, to help them make a fix.
Sorry about that.
No, it's all good. It's all good. Yeah, I think that's a great point. Like, our overall approach is very similar to your overall approach, in that we want to give people the tools to do it on their own. We just give them a little bit of help. And maybe you can explain how the functional side of the functional rehab orthotic works. He's already explained this to us when we first started doing orthotics and everything like that, and it's really cool. And I know for myself, I really didn't fully understand the way that the muscles in the lower leg really help support the muscles in the foot and keep some of that structure. So I don't know if you can go into a little bit about that.
For sure, absolutely. Well, that's okay. So let's start by rehab orthotic and how to sum it up and how it's going to work. Well, actually, no. Let's start by the actual biomechanics of the foot. Are we recording video as well, or this is?
No, it's purely audio. Sorry. Should have.
I'll just use this as like the football model for you and go through it.
Yeah, absolutely.
So we have to look at how gait function first, right? So because we invented shoes, mankind, humankind invented shoes. Now we started to walk a little bit differently than if we were walking bare feet everywhere. The barefoot walk traditionally over soft uneven ground would have been, mid-foot to forefoot striking pretty much all the time because you're walking light and you're trying to be light, hunting, et cetera, et cetera. Now the gait is more with the shoes. It went to a heel first, to a mid stance, to a forefoot loading, to a push off, right? So it's a heel to toe rocker motion of a gait. So what happens is you've got the muscles that are propulsing you forward and holding the arch up. You've got tibialis posterior, you've got flexor lucis longus, and you've got flexor digitorum longus. Those are your extrinsic flexor group, the main ones, and the prime inverters. And you've got the way that they're, obviously there's tons of intrinsic foot muscles, I'm not going to name them all, that help with this whole function. And there's the peroneal muscles as well that evert the foot and still propulse you forward. Like this whole structure of the foot, basically, when you're talking about flexor lucis longus, flexor digitorum longus, they lever against the calcaneal shelf and then lever behind the medial malleolus and attached to the lateral calf muscle underneath the gastrocnemius. So these muscles, by levering here, actually keep, on the calcaneal shelf, keep the arch from collapsing. So in gait, when you're heel striking first and then going to mid stance, their action works as they're trying to slow down and stabilize. So they're working eccentrically first, isometrically to stabilize, then concentric pull to propulse forward. So they're working essentially backwards, trying to slow it down, which is the hardest load for a muscle to hold, is to slow it down. So a lengthening muscle, right? It's kind of like catching a baseball or a heavy ball and trying to slow it down. I mean, your chances of injury are much greater when you're actually trying to catch it versus trying to throw it.
Right.
So if we go back to the foot, so the muscles, to recap, are the flexors are trying to slow it down, stabilize, and then contract to propulse forward. So those muscles are naturally weak in the North American population. That is a normal thing because for the simple reason that everybody has been wearing shoes since they were little babies. So why this is bad. Well, this is bad because you put your toes all together with very little action for the whole day for years and years and years and years and years. So it's just normal for those muscles to go mainly dormant. They're not being activated in the way that they should if we were to challenge them more with a barefoot walk. So this is why I'm so for, and I'm absolutely all for it for barefoot walkers and barefoot runners. It's just that people usually do too much too quick. We'll go back to that later. So now that we know a little bit about how the muscles actually work and hold up the foot and which muscles do get weak, that's important to get them stronger. Now, going back to the orthotic, so a traditional orthotic and a functional orthotic, when you're trying to correct gait, its job is to slow down that pronation of the subtalar joint when it happens. So basically, like, people will heel strike the mid stance, and then the muscles won't be strong enough, and then that arch is going to collapse.
Yeah.
So the traditional role of the orthotic is to support the foot so this doesn't happen as much. The role of the rehab orthotic from heel strike to mid stance is actually the same goal as a traditional orthotic, as a functional orthotic. Perhaps it's exaggerated a little bit in the rear foot. We like to really support all the way to the navicular to make sure that we slow down that pronation. So then when the body's weight is over top of the foot at mid stance, that we're hopefully close to neutral. Depends on the steps, obviously. Some, if you're dealing with different angles, and what we want to do, different ground angles. But what we want to do is, generally speaking, body's weight's over top of the midline, and we're at subtalar neutral. This is going to create an optimal sort of angle for us to put the foot in a position of power to toe off. So now the rehab orthotic, the way it works is it's not an actual arch support. So the arch actually drops quicker than the what the foot angle is and what the actual arch is. So what you end up having is sort of your proprioceptor muscles kick in, and your big toe and your first ray, the ball of the foot wants to make contact with that orthotic. Mm-hmm. So it will bring the first ray down and will be putting you in a position of power where the center of the weight is going to be over tip of the big toe, so you can toe off in a straighter angle. So to sum it up in the simplest terms that I can, the rehab orthotic is a rear foot stabilizer, but forefoot mobilizer.
Gotcha.
So it challenges it sort of destabilizes the forefoot a little bit and makes it evert the mid-tarsal joint a little bit quicker than traditional orthotics.
So it makes the foot actually work a bit, rather than, correct me if I'm wrong, but when you're walking in dirt barefoot and stuff, your foot actually is working to kind of stabilize and slow down that movement, absorb some of the impact, and that's where this really has a distinct way of training the foot.
That's right, exactly. So obviously the best way is to do it barefoot. Not everybody's going to get there, and it will take time for everybody to get there if we were all to try. But the rehab orthotic is the solution for us that we created for when we are wearing shoes.
Mm-hmm.
If we have to wear shoes, this is the best device that we have that's going to bridge that gap between the untrained, overpronated foot to the barefoot runner.
Yeah, and I think this is why this topic I find is so incredibly interesting, and the more I've looked into it is like we've fundamentally have changed the way we walk. Like how we're walking today is actually, arguably not correct. But we've really started relying on this new way of walking, and I think it's really interesting that the consensus out there of what the proper running form is or what the proper striking is, there's a lot of disagreement out there, isn't there?
Oh yeah, it's a volatile subject.
Yeah.
But the matter is, I don't think there's a correct way to do it. I believe that there is a way to, if your muscle mass is balanced over the whole leg, the thigh, the leg, and you have a balanced leg and balanced knee joint and everything is flexing and properly and has the proper range of motion, and you have strength to hold your joints together, then is it a bad gait? No, there's no such a thing as that. It's just that, there's a series of compensations that create imbalances.
Yeah.
And that's where the problem is. In muscle imbalances, one muscle gets too tight, one muscle gets too loose, therefore you start having a joint that tracks wrong subluxes, et cetera, et cetera.
So I was wondering for our listeners if you could give us just a brief idea what the different schools of thought, maybe there's not a correct one, but there's definitely different schools of thought in terms of
Like heel
heel striking, midfoot striking, and maybe even forefoot striking. Is there strengths and weaknesses you can point out kind of overall,
or at least even just like you said, it really depends on the anatomy, all of that kind of stuff. They're different strengths and weaknesses. Even if you could just give us like kind of a prototype, like if these muscle groups are strong, yeah, you can maybe do midfoot striking or whatever kind of thing.
Well, obviously, the more forefoot striking that is involved, the more you actually increase on the load that's going to be brought to the extrinsic flexors.
Yeah, because the lever arm's longer, essentially. Like if it's the whole length of the foot, then those muscles have to work harder. Makes sense.
That's right. So you're going to have a stronger foot, a stronger leg, a stronger calf to be able to withstand these impacts that are going to come. Like, I mean, there's just more force to the actual system.
Yeah.
Nobody's going to go out there and walk on pavement, even run on pavement, and forefoot strike. Like, it's just not, like, it's not going to be a very comfortable or efficient gait.
Yeah.
Naturally, gait just simply happens because we try to walk as efficiently as possible. So just with everybody's going to readjust their own gait to accommodate for anything that's hard and go around anything that's hard. For example, your typical ankle joint that's too tight due to gastroc soleus and hamstring being too tight, right? So the ankle joint doesn't get quite as much dorsiflexion as it needs for technically proper gait. So the body simply cuts a shortcut and externally rotates the leg and pronates the subtalar. So then all of a sudden that person doesn't have to work as hard and can have what seems to be an efficient gait. So I think like different gait types are all related to A, what you're wearing as shoes, and B, where you're running or walking. Mm-hmm. So you're going to have a way different gait if you are running with barefoot runners in a pretty rough trail. There you're going to be a lot more likely as you're jogging along to be forefoot striking, right? Because you're going to be like adjusting for the forefoot's got way more range into the mid-tarsal to adjust for different ground variations.
Right.
Heel, right? The heel's a single point. Your forefoot has got the whole range of the mid-tarsal to work with. So you've got way more stability there. Somebody that's going to have a way different gait if they're wearing dress shoes and they're walking downtown Calgary to go from a meeting to a meeting, right? It's just going to be a vastly different gait. And that's related to ground surface contact, proprioceptors, and what they're actually wearing.
Gotcha.
Right? So this is where we try to bring a little bit of the barefoot element back into a shoe, using orthotic. It's a train of thought there.
So you're almost looking at it as heel striking isn't necessarily wrong, or this isn't necessarily wrong. It's an adaptation to your environment, I guess, right?
Exactly.
So, I mean, nowadays there's kind of two big factors that people have to work around is, one, shoes, but two, concrete. We're not walking on soft surfaces anymore, so the heel strike makes sense. But I'm guessing, and if you look at like a tribe in Africa untouched by society, you're going to see a lot more of that midfoot, forefoot strike, correct?
Exactly. No shoes involved, way stronger feet. It's amazing if you, from the travels that I've done, and just noticing in less fortunate countries, how much stronger their feet actually are. It's amazing. It's amazing. They do way more. I once saw a guy climbing a rock face, bare feet, and I couldn't even climb it with my rock shoes. And
Wow.
start rubber on there, like pretty sticky. It's pretty hard to actually feel the sharpness of the limestone. And the sharpness of the limestone is just too sharp on that one. And this guy was climbing at bare feet, no problem.
Nuts. It's insane to think, at some point our feet were enough to traverse the world as it is, which is,
everything.
Danger and hazards everywhere you look. Super cool.
Invented, right?
Mm-hmm.
So we did invent footwear for protection, for perhaps there was some war elements to it that life got tougher and they needed to adjust for something. But footwear got invented, and now we're dealing with the aftermath of that and trying to kind of patch it up backwards. But I'm trying to be a little bit more proactive about it and bring some of that muscle stimulation element.
Yeah. And something we always kind of teach our patients is, whether it's a knee brace or a back brace or any kind of external support, it can be a good tool to get you out of pain or to go into a kind of, try something you're not 100% comfortable with. Maybe you have some knee trauma, you want to go skiing or... but anytime you add that external support, you're basically getting a dependency to it, and your internal support systems start to shut down. So a really cool concept. And when we're moving forward in society, it's all about making life easier and working less. And people don't realize that you're essentially making your body weaker.
That's right. Even in such simple things as if you look at footwear, as an excessive rocker shoe. I mean, this makes propulsing easier. There's definitely instances where I'll use a rocker sole. Don't get me wrong. I mean, some people really need it. However, generally speaking, a huge rocker sole will reduce the need for you to use your extrinsic flexors to propel forward.
Mm-hmm.
Right?
Which is actually interesting because back probably about 10 years ago, maybe 10, 15 years ago now, when they were first coming out with those rocker shoes, the idea was that they somehow smoothed out your gait and you could use your muscles more efficiently. And I remember, forget the exact brand, but they were toning shoes. They were what men and women wore to lose weight in their legs specifically. And then I remember about probably about 5 years after those had initially come out, they already had been doing research and EMG study, that kind of stuff. And they found that those are actually the absolute worst shoes. Muscle activation went through the floor. Everything was so much worse. But they were comfortable, people liked them, they thought they helped them lose weight, and so it's really interesting how that shifts in as little as 5 years sometimes.
Oh, sure, for sure. I mean, in the footwear world, it's so fashion oriented in the first place.
Yeah.
Which is a big challenge for health professionals. Absolutely, you see people walking in with a problem, and they are complaining about that problem, but yet you look at what they're wearing to come to the clinic, and we have a bit of a chat. We gotta have a chat about their shoes.
Oh.
We have to talk about shoes,
Right.
So, yeah. So that's always a point of that I find myself that I'm doing quite a bit of education on, for sure.
And that's part of it too, is people don't really know any better a lot of times. There are some shoes that are kind of okay, and then there's some shoes high heels is a perfect example, so bad in so many different ways, and so many people wear them for hours a day for years on end. A little bit of education there can actually go a long way to just be hey, maybe ditch the high heels or try this or try that kind of thing.
And the earlier the better, for sure. Unfortunately, it's kind of expected in society.
Yeah.
Certain jobs and things, and that's a sad thing, because it really does harm to the body, long term, hard to reverse, sometimes leading into really bad pathologies that require surgery, et cetera, et cetera.
Totally.
And, some people think like, oh yeah, I'll just get it fixed. I mean, let's never underestimate how intrusive a foot surgery can be to your health. Like, it's, in some cases, very necessary, of course. But generally speaking, if you can avoid it, please do. I mean, it's months off your feet that you're going to be on crutches, non-weight bearing. I mean, right there, that is a huge weight on the negative side to your health, right? So, and the rehab route after that is really long. So I would rather catch something earlier on, be able to compensate for it, and send that patient in the right direction, and we can help correcting things before they get bad.
100%. And not only the issues that arise in the foot, but as chiropractors, we know that it's causing more compressive forces in the knees, but also your hips, especially just being in a kind of constant state of hip flexion just shuts off your abs, can shut off your glutes. And the way I come to understood it is people's feet are too far ahead of them, or people's legs are too far ahead of them. They're never really extending through their pelvis, and it really just propagates through the whole body. The whole curvature of the spine gets completely thrown off. So as much as heel striking is adaptive for us walking on concrete, it's it kind of screws up the whole alignment of the spine and everything associated with it.
Oh, absolutely. Absolutely. Couldn't agree more. Yeah, this is where, people are always a little bit surprised when, it's not about really, dynamic foot orthotic is not about just the foot problems. It could be, coming from the knee, the hip, excessive, it creates, like you were saying, people don't, they can never fully extend through the hip. Well, that creates tight hip flexors and, SI joint problems, and et cetera, and excessive lumbar curvature, lordosis, creating, a lot of the problems that you're familiar with, that you're seeing every day. It's amazing on how the correction of the foot will go right, the immediate one is to the knee. It just reduces the valgus loading of the knee. And, we're living in a day and age where we got so many sports that actually increase that valgus load and make that knee joint prone for injury. I'll just throw an example there, Alpine Skiing. Alpine Skiing is a sport that even the footwear that we've created, the ski boot, forces the foot into a valgus load. The inverted overlap of a front entry boot, when you clip the instep buckle, it will absolutely put so much pressure on that metatarsal joint in the subtail, it will force the foot into a valgus load. So that goes immediately into the tibia. The tibia rotates inward, a medial rotation of the tibia, which creates a valgus load to the knee. Now add the turn to that, and you're increasing that valgus load. So for our listeners out there that don't know what a valgus load is, it's basically rotating the knee internally excessively as you're doing an activity. So you can just imagine somebody that's not kneed and going further into a not knee A-frame style stance.
And they're skiing.
You're into a ski turn. I mean, there's a reason why ACL injuries are the number one injury in skiing. It's literally caused by the valgus load of the knee, that's caused by the ski boot.
Right, and for our listeners, imagine your knees are pointing inwards, right? You're literally knocking your knees together.
Exactly. So,
that's really interesting, actually, that you say that, because I've always known that skiing, not that it's bad for your knees, but that's how you get a lot of injuries, especially the classic ACL, MCL, medial meniscus tear. And I always thought that was more of an issue with keeping the tibia like anteriorly to posteriorly aligned, and the fact that if you imagine you're on a ski boot, and if you were to fall down onto your butt while your shins were still vertical, like obviously like that's an ACL tear, that shin goes forward, that's how you do it. But I had no idea that it's much more of the rotational force through the knee. That makes total sense. Like the knee, it rotates a little, but it's really supposed to be a hinge. So if you're getting a lot of pressure on that one side in that rotation, like that's just a recipe for disaster, especially if the foot's weak, especially if the ski boot's tight. Like, makes tons of sense to me.
Well, and then add to that your inside quadricep muscle, the BMO, the vastus medialis is going to be like the more knock-kneed of a stance that you are, the more that muscle, the less that it gets challenged and the weaker that it gets. Same with the hamstring, same with the glute, and you end up having a really tight IT band. Lateral quad, which tries to compensate and straighten things out, which ends up torquing the patella to the outside, creating that extra friction and a lot of the pain that people are initially feeling into that patellofemoral syndrome.
I love that you were able to break that down, because it's something I've known, but it's kind of hard to wrap your head around that domino effect, right? Like your foot, you don't have that support, your arch drops, that turns your tibia inwards, that turns your knees inwards. That's going to shut off your, VMO, shut off the glutes, and then it's, everybody you look at, they just got the tightest lateral quads, tightest IT band, and it's just the most common issue.
That's right. So a lot of it is initiated by the foot stance and posture.
Yeah.
So, it's actually, with body awareness, the right exercises, and the right device under the foot to help out in situations where you can't think about your feet like such a way when you're in footwear, or if you're in ski boots, you're definitely not thinking about your feet if they don't hurt.
Right.
So you're always going to be thinking about your foot, but so the main idea is to give it the proper support structure underneath, make your muscles work the way that they should, and then rebalance the whole leg. I mean, we're talking about muscle balancing the whole, and how that relates to the optimal gait. Well, going back to that, I don't think there's like such a thing as an optimal gait. I think the only thing that we should look for is proper muscle balancing for the joints to work properly.
Right. Yeah.
So I had a question. Obviously, you're the foot guy, because we're chiros. We're like the hip and spine and pelvis guys. So it's always like a chicken and the egg scenario. Like, is it the feet causing issues in the hips? Is it the hips causing issues in the feet? Like, is in a hypothetical scenario, would you be able to strengthen the hips enough to stabilize the pelvis and go all the way down into the knee, into the foot, all that kind of stuff? Or is it really just a ground up that you need that base of support to help you?
Great question.
It's an amazing question. I personally like the ground up approach for one reason is it's easy to teach myself on how to do it. Mm. So then it's easy for me to teach somebody else which muscles to target first and how to adjust the stance from the ground up to correct, right? So for instance, quick example of that. So I'll line up somebody on the hardwood floor with two lines, and I'll use the heel, and I'll use them like in the regular stance. So let's just say that this patient's an overpronator, so they're externally rotated in their standing stance, okay? So I line up the heels so they're on two lines, and then I'll show them how to internally rotate their feet so the midline is not the big toe at the tip of the distal end. Mm-hmm. But we're going to go for in between the second and third metatarsal heads.
Yeah.
So by going to that angle, they feel extremely knock-kneed all of a sudden, right? So all I've got to do is flex the knees forward a little bit and then show them how to externally rotate the knee.
Right.
Which immediately brings up the arch.
Yeah.
So I do it by tibial torsion. I show them by rotating the tibia outwards, rotating the knee outwards, and almost thinking like they've got like a little ball in between the knees to kind of separate them. From there, it is much easier to show them to stand a little bit more on the forefoot and then to be able to straighten the pelvis and open the pelvis.
Right.
And by opening the pelvis, then I've got a flatter lumbar curve.
Mm-hmm.
And by having a flatter lumbar curve, it's now much easier for somebody to stand straighter and the shoulders fall back and the neck falls into less of a reverse curve, depending on how exaggerated the case is. But basically, the neck straightens, the upper back straightens, the lower back straightens, everything straightens from that hip stance that you were describing before.
Yeah.
By being able to open up the pelvis.
It's so funny you kind of see it that way as like this is an easier area for me to tackle, where for us, I know for me especially, and I'm assuming for Alex, it's like when we're working at the hips, it's like if I got to pick my battles, like I want to work the hips because
that's what I know.
we find it, and also there's these big powerful muscles that we can have more of a profound effect on in our eyes, and it's a little bit easier for us to try and correct the pelvis and make that effect by working on the tissues and working on the hips and the lumbar spine. But for you, it's you're the expert on feet, and that's an easier thing for you to tackle.
And it makes perfect sense to me, like just the way you describe it, to teach a patient to not internally rotate those tibias and like provide that structure to lift those naviculars, like that is way, way, way easier than me trying to explain like some way to adduct the hip or like squeeze the glutes. Like there's no way that a patient's going to kind of put two and two together and get that same kind of foot engagement. Mm-hmm. Whereas I think it's easier for them to be like, once they get that solid, it's like, okay, squeeze here, push out here, externally rotate your hip. Like that makes more sense. But for the tibia itself, like I don't even know how I would explain to do it other than the way that you just showed us how to do it. Yeah. So it's a good way to do it.
Try it next time. Just try to just literally just rotate the knees out. Like once you've got you need to have the proper foot stance first, right?
Right.
So once you foot stance, using the midline between the second and third met heads, then from there just flex the knee forward a little bit and just externally rotate the knee.
Totally.
Right? And you get them to straighten a little bit, straighten that knee back, and then extend and open up the hip joint.
Yeah. And our jobs is totally about like, do you know the best cues for someone?
Yeah.
Right? Because this is something we could go in hours explaining how this affects the
Seriously.
biomechanics, but if you just tell someone, hey, like, get your knees right over this, met head.
And push them out.
Slightly, it's like, correction in every part of the spine.
Gap over the third toe.
Yeah.
That's the cue.
That's it.
Right?
Yeah, and that's way more simple than trying to explain like all these complex interrelations of mechanics that we're talking about. Like you're not going to be able, as soon as you push your knees out, you're going to activate the hips. Like, period, done.
Yeah, super easy to get out in the weeds when you're trying to explain something when it doesn't have to be that complicated.
Yeah.
That's the one challenge of both our professions is always to be able to simply, efficiently break it down into understandable words and doable cues, right?
Yeah.
So, for sure. No, this is the... Okay, go ahead on the next question. I can see you guys.
Sorry, I'm just... There's so many questions that kind of bubble up in my head. But the other thing I just wanted to quickly mention is, as far as having that... We live in a world where comfort is king, and that comfort causes a lot of weaknesses in our body. And when we're working with the hips, it's like we're sitting... People sit for 8 to 10 hours a day easily, which causes so much hip flexion, so much tightness in the hip flexors. It's kind of analogous to wearing these super, super supportive shoes, right? It's a comfort thing. And that's a main issue at the hip that we try to correct.
Yeah, the hip is a complex one, and it's definitely, it can be a problem for a lot of people. Absolutely.
So I kind of want to get your take on this, on the term overpronation syndrome. Is that an oversimplification, or do people kind of typically fall into the same syndrome and it's just kind of an extent, and maybe there's other variables that are contributing to that syndrome, but is it more of on a scale of how much do we deal with this, or is that term just too much of a blanket term?
Well, it's a bit of a blanket term, but at the same time, it is describing what originally causes the different pathologies that show up. For example, you can have, so an overpronator that's developed a navicular drop and posterior tibialis tendon dysfunction, or you can have an overpronator that developed a hallux valgus deformation, et cetera, et cetera. So it starts by the overpronation bracket, and then where does it go from there? Or do we have any external or extra complications with that foot? It could be overpronation that would start the cause of a patellofemoral syndrome up in the knee, or meniscus tear, exactly. So to answer your question a little bit clearer, no, I think it's a necessary term. Like I'll use it, and sometimes I'll be discussing a patient's case, and I find I'll write it in my goals for the treatment plan, and I'll find myself using the same words, and it's almost like a little bit annoying. Like, okay, here we go again. I want to slow down the pronation, and I want to stabilize the hypermobility of the subtalar joint. That it happens very often that I write these words.
Yeah.
Is it overstated? No, I really do think that it's just that common.
Right.
My own guesstimate, this is from over 20 years in the field, and living on this earth and noting what I'm seeing around me, and then working with, now over 250 practitioners, this general consensus that it's about 3/4 of the North American population would be classified as overpronators at mid-stance.
Yeah.
So 3 out of 4 that would walk into your door, we do a test, and we take their shoes off, and we put them in shorts so we can see the knee, or ideally leggings so you can see, hip, knee down, or just have a quick look, and just to see how is the calcaneal stance looking. Is it vertical? Is it inverted? Or is it everted? Well, from what I've noted, and this is just a guesstimate, but it's about 75% would be on an everted calcaneal stance and somewhat overpronating at mid stance. You'd have about 15% of people that would classify within in between brackets normal limits, and then you'd have about 10% that would be more on the other side, in the high arch kind of more rigid type foot structure. We call those cascadas. Definitely more rare, still quite common at 10%, but that has completely different implications and a different treatment plan, and different challenges that come along with cases like that.
Gotcha.
For sure. Yeah.
So it's almost, the overpronation syndrome is almost a constant. It's just how is this going to manifest problematically in a lot of ways?
Exactly. So then you look at, first of all, has there been any complaints? Are we talking about plantar fasciitis symptoms? Are we talking about, knee pain, back pain, whatever it might be? So we'll start looking at the whole stance and see where this might be problematic in the future, or is it already problematic and we're trying to compensate for it?
Yeah.
Yeah.
And I just wanted to touch on one thing you said, and that's 15% of the population, as an estimate, actually gets it right, which is crazy.
Surprisingly low.
Very
Surprisingly low. Yeah.
Get it right is a big thing. I didn't say that.
Oh, you didn't say that.
Yeah, that's right.
That's me making an assumption.
15%, not that
In
bad.
the normal. But it's funny that normal is an uncommon thing,
Yeah.
or what we consider normal.
Seriously.
I would say, instead of normal, I would rather use the word efficient. The joints work efficiently enough that it falls within the category of the joint is working properly, not causing an imbalance.
Yeah.
Yeah.
And pes cavus, right? It's how is that just because typically these feet are just so rigid that they overcorrect? Do you ever find that these intrinsic support or extrinsic support muscles are just working so hard, or is it more of these feet are just so rigid and locked in, and these joints are just so kind of immobile? How do you find that?
It is. The problem lies in joint mobility restriction. So the foot in itself is a suspension mechanism. Right, so we can simplify it. Like if you look at an overpronating foot, you have a foot that's very, very mobile. So mobility is not the problem there. They have a great shock absorption, but the problem is the tightness of the suspension here. We have a suspension that's too loose. So the suspension's bottoming out if you're changing it in a mechanical perspective. Like just imagine you're looking at a car shock. Like this shock is too soft, and we're bottoming out every time I'm hitting a pothole. That's an overpronating foot. The opposite side of the spectrum, the pes cavus side, you've got tight peroneals, you've got tight extrinsic flexors, you've got tight extensors. The problem is there is no shock absorption. So you're dealing with direct shock transfer from heel to met head that gets transferred right up the leg. So this foot's problem is that it is very heavy on the points that it does actually load, and not heavy at all on the other points. So we want to be able to redistribute that pressure load over the whole plantar aspect of the foot. So generally how that's done is by, so if you've got just imagine you've got a very heavy heel spot and very heavy on the ball of the foot, for example, first metatarsal head. So you would create a device that would be an accommodative device that would be, a full arch support, and even pressing into the arch actually a little bit more than that actual arch may be. So the idea is going to be to just, donut pad principle. If you have a heavy pressure spot, you would load the area surrounding the pressure spot, and you would reduce the area of the actual highest point of pressure. So by loading the mid-arch, you're offloading the first metatarsal head, and you're offloading the heel. And then by, you'd have to cup the heel really good. And what we do on top of that is we make that orthotic flex a little bit. From the arch down, so in a vertical flex fashion, so it gives that patient a little bit of sort of make-do suspension, would be how that actually works. So those are actually typically the harder problems to deal with, because you're dealing with restricted or rigid joints. Anytime it's rigid, you got a serious accommodation to accommodate.
Gotcha.
So question with that type of orthotic is if they do have like congenital malformation of their midfoot or whatever it is, the reason why they have that is due to the actual structure of their bones. Would you ever even make it a little bit higher? Like, are you trying to separate some of those joints in between the mid-tarsals just to give it a little bit more movement? Or is it mostly just supporting the structure and offloading the hot spots kind of thing?
Well, I mean, it all depends on the actual case. Ideally, if you do have, like, throughout the assessment, I'll encourage highly to do, all sorts of different mid-tarsal manipulation and trying to get, the cuneiform, the Lisfranc joint to actually open up a little bit separately, so you can work on like the raised, the Lisfranc height, the mid-tarsal on both axes and the subtalar, and trying to get everything moving independently a little bit more and trying to incorporate it into my treatment plan to show this patient on how to work their foot, and we're going to have to work it every day to try to get some mobility back in the structure. But yeah, I mean, it's a tall order sometimes, for sure.
Okay. So this would almost be where we would shine the most as chiropractors. We go in there and we just do everything to get all these individual bones moving, correct?
That's right. Exactly. And I'll try and offload some of these heavy areas that can show up. And this is where we work as a team, and we can figure out exactly what we're trying to offload within the orthotic, and having the best communication as possible between the patient, the chiropractic team, and the orthotist, and trying to make sure that this device is going to be as efficient as possible for that patient to regain as much motion as possible.
So go ahead.
To answer your question, sorry, I kind of went away from your question. Yes, there is an element. So if I'm taking an accommodative orthotic, so imagine that we're going to go and match that arch, right? But what we do is, throughout the design software, we would bisect. So the foot image, the 3D volumetric scan of the foot would be standing on this orthotic within the software, and you can bisect it any which way. So meaning you're taking a knife and slicing right through, and then you have a look at the relationship between the foot and the orthotic. And right at about at the apex of the arch, we would lift that up a little bit to try and offload. So we're trying to pressure that arch a little bit, and to help display the tarsals, yes, but at the same time to definitely help offloading first metatarsal, the metatarsal group, and the heel, or any other heavy spots that you need.
Gotcha. So when we're going through, as you were talking about the assessment for assessing and fitting for orthotics, if they do have those restrictions within the bones of their foot, is it beneficial for like me and Dr. Matt to mobilize or adjust those in order to get more of like an optimal picture of what their foot can actually do? Or is it better to have them present exactly like they would in real life? This is how their foot is most of the time. Do the scan that way, kind of thing.
That's a very good question. It depends on, like, ideally for the optimal scan, you'd want the foot to be at the optimal position.
Right.
Optimal, like whether it's, so let's back up just a little bit for our listeners. Whether it's a digital scan of the foot, using contact digitizing, using laser scanning, or whether it's a plaster cast or a foam box impression, the idea is always the same, is to get the best impression as possible of the foot, to be able to translate it into the best possible functional orthotic for the patient. So, but in this case, we're talking about a scan. So, believe that it's always best to have the foot at its optimal position for the casting, whether it's a digital scan or not. But the mid-tarsals being mobilized for that patient at the same time, is it going to change that foot structure that much? I think probably not.
Probably not.
In terms of how it's going to measure, it's going to be pretty similar, except if you can bring mobility through manipulations to these joints, I think it's absolutely let's do it for sure before the scan or after the scan. But I don't think that it would really change that impression of the foot. I think that the foot is going to, unless there's something completely locking it into like a huge 4-foot valgus kind of thing, and then you would unlock it and somehow that would correct the forefoot to rear foot relationship. In that case, depending on how strong you feel about this instance reoccurring, and if you feel like this is likely to reoccur, then we're perhaps better off to take a scan or an impression in the typical everyday position if it's likely to reoccur.
Gotcha.
Did that answer the question?
Yeah, no, that was perfect. And from my experience, that's yeah, exactly.
Just circle back, yeah.
That's in my experience, that's exactly what I find too. That if you do have a really rigid arch or something like that, that's what the problem is anyway. And so you're not really going to get that much motion out of it, especially if you're just mobilizing for a scan or whatever. So yeah, I agree with that.
And as far as mobilizing goes, say we're working with an overpronator, and generally we try to, kind of seek and destroy when it comes to joint restrictions and issues. Do you think it's better to leave the Liz Frank joints alone, the subtalar joint alone, and leave that kind of joint stability alone? Or if there is, rigidity in that area and they still are an overpronator, do you find it's better to try and open those joints up?
Absolutely, open them up. Absolutely. Yeah, mobility is key. Obviously, hypermobility, you wouldn't tackle that anyway, so you're only tackling it if there is a restriction.
Right.
The typical, in between brackets here, the typical case often has actually a restriction in ankle joint dorsiflexion.
Yeah.
So this is a fully let's tackle this as soon as possible. You're a very common thing is that gastroc, soleus, and hamstring tightness will pull on the Achilles tendon and create a traction, which will then tension the intrinsic structure of the foot underneath in the plantar aspect, right? So if you have a calcaneus, which is the heel bone, that's getting pulled upwards by a tight Achilles tendon, coming from the muscles that are above it, that are pulling on it, then you end up having your heel bone that's sitting sort of further back and more stretched. So that, in terms of when you land on it, you're totally increasing the shock load to the tendons that are attached to that heel bone and that go into your foot. So often people will describe deep pain that originates just forward of the heel bone, so just slightly distal, but it does often come from the calcaneal oblique tendon and the deeper intrinsic structure that's so hard to get because it's like you got to go underneath all the layers to finally get that stabilizing tendon, and that can, when it's really stretched, it can cause little ruptures, heel spurs, and so on and so forth. And that is very often caused by a restriction of dorsiflexion of the ankle, and patient compensates by externally rotating and pronating the subtalar joint. So, so to mobilize that ankle joint from your end is key.
Huge, yeah.
And that's really interesting that you described that symptom presentation like that, because that's how the average person would describe plantar fasciitis to me. They say it's not on the very tip of the heel, it's kind of a little bit in front. They might have some bone spurring, they might have some sharp pain. And I've actually found that some people, when they do go in for treatment for plantar fasciitis, the person will just work mostly on the bottom of the foot, maybe a little bit on the top, but very rarely up into the leg. So it makes total sense that if all that stress is coming from those big muscles in the lower leg, what are you really going to do with that attachment point at the bottom of the foot?
Mm-hmm. Right. So a lot of the stress I find is coming from a lack of strength in the extrinsic flexors that could be stabilizing that calcaneus, the heel bone. So it stabilizes the amount of pronation that happens. So you reduce one part of the equation there, and then to be able to loosen the gastroc soleus and all the other elements coming from the top of the leg. So you're going to end up reducing that posterior tilt of the calcaneus, and you're going to end up stabilizing it from the strength of the flexors, greatly reducing the actual amount of tension that's within the plantar aspect of the foot.
Mm-hmm. Yeah, so cool. And for our listeners, like, it's your calf being so tight will actually kind of flatten the foot and put more stress on the bottom of that foot and those tissues that are meant to kind of hold the arch in.
Exactly. So a typical treatment would be for somebody that's suffering from plantar fasciitis syndrome for symptoms, and I'll put plantar fasciitis in between brackets because I believe that is an overused term.
Yeah, definitely.
Mm-hmm.
So yeah, it would be some muscle lengthening work in the gastrosoleus, the calf muscle. Yes, perhaps some activation. If you have seen shockwave being used like underneath, like just to try and pinpoint the actual injury spot, trying to get some blood flow back in there and maximize healing efficiency. But I would always prescribe toe lifts and calf raises to try and from the toe to really focus on retraining those toe flexors in order to stabilize that subtalar. And then that's a big one. And your orthotic treatment, what we're going to do is make sure that heel, that orthotic is fully cupping the heel as much as we can. And try to really minimize that pronation of the subtalar, and then just max it so it has as much forefoot activation as possible for retraining those flexors.
Yeah, cool. Mm-hmm. And I kind of wanted to pick your brain about the importance of our big toe and its ability to extend. And I kind of have a side story for this. So I broke my foot in an unfortunate sledding accident, and so I kind of dealt with the break in my foot and healing from there. But afterwards, there was this whole several months where I'm still healing from all the compensations that went on because of it. But really something that I am kind of concerned about is my toe is kind of healed in a valgus, my big toe, in a valgus way, and just having that abductal valgus malformation now, I've noticed I have calluses forming, and I'm hoping it's not going to be, altering my gait super traumatically. However, I know that it definitely can. What's your thoughts on that? Can I pick your brain a little there?
You're screwed.
Screwed? I'm a freak?
Cut it off.
Well, it depends on how mobile you're. Can you still abduct your house? So, for listeners out there, can you still bring the big toe sort of inwards towards the midline?
I can. Yeah.
Okay.
Yeah.
So if it still has mobility that way, then I would focus on retraining your abductor muscle, abductor hallucis, your intrinsic muscle.
Yeah.
So it's a bit of a tall order because it's a funky one to activate.
Mm-hmm.
But you can definitely do it nonetheless. I would do it with encourage the toe spreaders. Not in your shoes, but basically at sleep, to try to get as much toe spacing as possible. And I would encourage you to do squats on a Bosu type ball, with manually basically setting your big toe to where you want it to be, as spread out as possible, and then to do squats that are a little bit more onto your toes. You can lift up the heel if you want, to aid that angle and keep yourself balanced. And that would be the start of like recuperating the proper muscles for straightening out the hocks. In terms of orthotic treatment, perhaps adding a little post underneath your first metatarsal head, to lifting it up a little bit, would change a little bit on how that would sit. So instead of requiring it to flex so deeply and finish in a abductor valgus position, we would lift up the first metatarsal head just a little bit, basically slightly plantar flex the joint, to require less dorsiflexing, so you don't end up in the adductor valgus position.
Okay. Wow.
So that's almost like the first thing that came to my mind is like when weightlifters wear shoes with heels, it's to kind of shift all their weight forward to essentially give them like extra dorsiflexion range. So it would be pretty much the same thing with him. If you just lift that up, then it doesn't have to go as far. The post is already helping him, so then his range is more like normal kind of thing.
Exactly. So I know that we're in an audio podcast, but I'll show you. Since we were in video, I don't know if you can see this elevation right here.
Yep.
Mm-hmm.
So that would be what would be required in an orthotic like that.
And that's right under the MTP joint of the first toe?
Yeah, it lifts up the first MTP, and it doesn't go that far up into the proximal phalange. It's just basically lifting the joint here, and allows the distal phalange to be a little bit lower, so it kind of makes it changes the functional range of motion of the joint.
Oh, okay, gotcha. So when it can extend. Wow. We've tackled a lot, and I actually need to pick your brain about one more thing, and it's leg length inequalities. So a lot of times when I check these things, I notice their pelvis is off. People are amazed and surprised that they actually have a longer leg on one side. People don't realize how actually common this is. And, people have been compensating for it most of their lives, assumingly, especially if it is a structural issue. So where do you stand on, is this something that a lift should be implemented on? Is there a kind of a range where it's okay? How do you feel about that?
That's a loaded question. Depends on a variety of factors. So question number one is, how long has that patient been compensating, and how much is the compensation for? So as a rule of thumb, I don't encourage that we correct more than 50% of the actual measured leg length discrepancy. And that's a measured
on X-ray,
the bone relationship, and we're not, just so everybody's clear, we're not talking about a functional leg discrepancy which can be adjusted by your work. So if you can do manipulations and adjust them, and after your adjustment they're back to a straighter, more equal pelvic height, then I don't believe that there should be an adjustment within the orthotic at that point.
For sure.
If the leg length inequality is actually structural, then there will be likely some benefits into increasing the height of the shorter leg, by up to 50%.
Gotcha.
That makes sense?
Yeah.
So, depending on how sort of severe the condition is. Like I've seen, post-surgery patients that have been, completely destroyed ankle and they're locked in a inverted plantar flex type stance on one leg.
Yeah.
Creating severe leg length discrepancy. So in that case, there's no way that it can be done with an orthotic alone. We're talking about the severe shoe modifications and then just trying to adjust for something that's going to feel somewhat equal to that patient.
Interesting.
But for somebody that has tight hip flexion on one side or something that pulls the hip up on more on one side than the other because there's a dominant side, and then after adjustment they straighten.
Mm-hmm.
The max I would do for that patient is probably try an external heel lift and then slide it underneath the orthotic.
Mm.
And see if we get temporary relief as things balance out through the treatment plan.
Yeah.
Right. So then that way, as everything gets stronger, they no longer need the heel lift because those muscles are more in balance and they don't have that leg length discrepancy anymore.
That's right.
Gotcha.
Yeah. So clearly it's a complex thing, and
Yeah.
that's why we need the specialist for it.
That's right.
And for our listeners, like structural or anatomical leg length inequality is like you literally have longer bones on one side.
Yes.
Where this issue can arise, where you just have tightness in muscles on one side, your body is shifted, your pelvis is shifted, and that results in a differing leg length that isn't necessarily baked into your bone structure. Anyways, I'm super glad. I know this is probably a hard podcast for a lot of people to follow, but an incredibly interesting one, and I hope listeners were able to take away some key information about it. Very complex structure of the foot, so I'm glad you were able to break this down for all of us. I found this incredibly interesting.
Yeah, I'm a huge anatomy nerd, so I love talking about all this stuff. Like, absolutely love it. So,
yeah.
Same here. Awesome. So, any more questions that we got, or that's kind of a wrap up?
I wanted to get, if you have any closing words for our listeners, any key takeaway points?
Yeah.
Key takeaway points. I wish I would have prepared for that.
Well,
if you want to be proactive about your health, it doesn't hurt to get checked and go for an assessment with professionals like Dr. Matt, Dr. Alex, and orthotists like myself. So just to seek the help even before the problems arise, I think would be a really good thing, especially if you as a person are an active person and want to keep active for as long as possible. It's important to have those joints well balanced, the muscle balance, and working for your body, not against your body. So these are all things that can be checked, and I would encourage everybody to kind of seek the proactive approach rather than the treatment approach when things have actually gone wrong. So, but regardless, if things go wrong, then we can fix it. We can help.
Yeah, absolutely. And it's cool that we're kind of faced with a role where technology and society is moving faster than our bodies can adapt for, and we're trying to mediate that situation. Walking on cement, wearing shoes, sitting all day. Our body wasn't made for that, and we're trying to mediate you so that your body can cope with all these changes.
That's right.
Yeah. So thanks for coming on. We really appreciate it, and that was just wonderful, great information for all of us.
Oh, it's a pleasure. It's a pleasure. Thanks for having me.
Mm-hmm. We hope to have another session at some point here.
We'll definitely have to at this point.
Yeah.
The restrictions fully lift. I can't wait for the time that I'll be able to tour our affiliated clinics around and see everybody. It's going to be great.
Yeah, absolutely. We'd love that.
Awesome. All right. Take care, my man.
Okay, thank you guys.
We will see ya.
Yeah, sounds good.